and welcome to SureenaSpeaks, and in this video I'm going to go over some of the changes that have been made to the BNF 75. So this refers to March to September 2018. Now some of these changes they relate to updates to NICE guidelines, general updates, MHRA updates. So I'm going to try and cover some of the familiar sounding medication that you will be more aware of, but do bear in mind that there are a lot of updates and all of this information can be found on online BNF. I will include the link in the description box below, so do check it out. But some of the updates that have been made are to some really obscure medication which aren't commonly prescribed or actually commonly seen, especially in community. And with a lot of them, they are very weird sounding. So for example, there's some NICE guideline changes to aflibercept, to cladribine, naltrexone with bupropion, nivolumab. The list goes on, and yeah, like I said, you may as well be learning a different language, but there are some NICE guideline changes to them, so do check them out as well. Other update guidelines refer to, for example, with terbinafine, so and in terms of hepatic monitoring and advice, malaria prophylaxis. So the BNF, they have a section in there where they have all different countries listed and the recommended malaria prophylaxis that would be recommended to patients travelling to those different areas. That has now been updated to different country recommendations and guidance, so do have a look at that. Also be aware that Malof Protect is now available. It's available over the counter. It contains atovaquone and progranil. As this is something that's come new to market, well, in this particular brand, it is something that the exam might ask you on, so do bear that in mind. There are also updates to sinusitis, endometriosis, and even to emergency contraception. And that information can be found at the Faculty of Sexual and Reproductive Health guidelines, which they have in a PDF format. Again, I will include that in the description link below. So if we look at some of the updates that have been made, this can be to do with osteoporosis and treatments for osteoporosis. So for example, alendronic acid, ibuprofenic acid, risodronate. And these updates were made in February 2018. Some of the changes that have come about are, for example, NICE guidelines has been updated with regards to actually assessing the risk of fractures. Who is eligible for the relevant risk assessments that there are for patients who have had osteoporotic fractures. So it's really key that it's looking at fractures relating to osteoporosis. Also, patients who have suffered from a major osteoporotic fracture and looking at their risk of potentially having another fracture in the next 10 years. And this would be based on a fracture risk assessment. So as mentioned, we can use alendronic acid, we can use ibuprofenic acid, but these are only recommended options for treating osteoporosis in patients if these 2 points are, if they're included in one of these 2 points. So one of them, if the person is actually eligible for having a risk assessment as defined by in the NICE guidelines on osteoporosis. Like I said, with these fractures, it has to be osteoporosis related. And the second point is if that 10-year probability of getting osteoporotic fragility fracture is at least 1%. So like I said, this can be found in the link below to do with the BNF online. So if you do want further details, do click on that below and do also check out the NICE guidelines too. So moving on to the MHRA guidelines and some of the updates there. One of them is with the use of corticosteroids, and a very rare risk of getting something, might not be saying this right, just stating that right now, but something called central serous chorioretinopathy. Yeah, and what that essentially is a retinal disorder, and so what patients are recommended if they are on corticosteroids and suddenly they get any changes in their vision, visual disturbances, any blurred vision, that they do go and see an ophthalmologist. Originally, it was something that was at risk with systemic corticosteroids, but actually there have been a few reports now of even patients that are using local corticosteroids. So for example, inhalation or if intranasally. So my suggestion would be for any prescription that you see for corticosteroids, that you do let your patients know and counsel your patients on the risk of getting any eye disturbances, and if they do get any eye disturbances, that they do seek a medical professional ASAP. So now talking about dihydrocodeine with paracetamol. So originally codidromol was only available as 10 by 500, so only one strength was available. But now, as of January 2018, there's two new strengths available, 20 by 500 and 30 by 500. Therefore, the MHRA are recommending that we prescribe and dispense by strength to try and minimise any potential errors with regards to codidromol. So the next MHRA alert that I want to mention is actually about Esmya, which is Ulipristal acetate, and this can be used for uterine fibroids. Now, at the moment, it's currently under investigation to see if there is a link between potential liver injury and patients that are on Esmya. At the moment, the MHRA is saying that no new treatment courses for patients should be started, and that patients who are currently on Esmya need to have a liver function test done at least once a month, and again 2 to 4 weeks after stopping. It needs to be made aware to patients, women who are taking it, to look out for any signs or symptoms of liver injury, and if they do have any signs or symptoms, they need to seek medical attention straight away. They will need to have their levels of transaminase checked out, and if it turns out that their levels of transaminase are actually 2 times higher than the upper limit, then it needs to be stopped ASAP, like it needs to be stopped immediately. And again, as pharmacy professionals, we do need to counsel our patients on the signs and symptoms of liver damage, especially those patients that are taking Esmya. So the next one I'm going to talk about is Fingolimod. Fun name to say, and it's actually used as an adjunct in multiple sclerosis therapy, but there are a few MHRA alerts surrounding it. One of them is to do with cardiac events, another one with cancer, in particular skin cancer and lymphomas, as well as infections. So if we start off with cardiac events, so actually Fingolimod is now contraindicated in patients with pre-existing cardiac disorders. The reason being is because Fingolimod can cause persistent bradycardia. This could then lead to cardiac arrhythmias. With regards to cancers, new advice has been issued with Fingolimod. So any patient, before they start treatment with Fingolimod, they will have all their skin lesions looked at and assessed, and again reassessed in every 6 to 12 months. They will need good advice on protection against those harmful UV radiations, and their skin very, very closely monitored throughout treatment. So any patients that may have any suspicious lesions will need to be referred to a dermatologist. And in regards to infections, Fingolimod has been associated with something called fatal fungal infection. So as mentioned, there's new guidelines and advice with regards to these aspects. Moving on to mycophenolate mofetil. Now this is used in patients who have had transplant. And the MHRA advice that at the moment that is out there is for male patients who are taking mycophenolate mofetil, and actually that they have proper contraception, which makes a change because usually it's to do with females and contraceptions. But in this case, it's male and contraception because mycophenolate mofetil is genotoxic. Therefore, there is the potential of there being miscarriages or malformations in pregnancies when the father has been taking mycophenolate mofetil. Now, there aren't any studies actually to suggest that there is an increased risk, but there is a potential. That's why any patients that are on, male patients that are on mycophenolate mofetil, we do need to make sure that we do counsel them on appropriate contraceptive advice. The next one I want to talk about is Headlice products, and actually it's been shown to be that some of them are combustible and flammable. So patients who have been treated, have had their head treated by Headlice products, they need to stay away from open flames, for example cigarettes. So even if a patient has had an overnight treatment, when they wake up in the morning, they still need to be away from any source of open flames until their hair has been thoroughly washed out. So the next one I want to talk about, which I find actually is a very interesting one that's come about, is Valproate, valproic acid, sodium valproate, and its use in women and girls of childbearing age. Now, if valproate medicines are contraindicated in women and girls of childbearing potential, unless they are under the pregnancy prevention program. So it's really important to stress that out. Unless they're under this pregnancy prevention program, it is contraindicated. Reason for that being is that valproate is highly teratogenic, which is why these new this new guidance of patients being under the pregnancy prevention program have come about. Now, Valproate, it must not be used in women and girls with childbearing potential unless the conditions of the pregnancy prevention program are met, and as pharmacists, we can help to make sure that this is put into place. So women and girls, they need to be fully informed of the risks and why it is so important that they avoid exposure to valproate medicines in pregnancy. So patients, they will be given something known as a patient guide. This needs to be checked and reviewed by a specialist in the last year, and specialist needs to make sure that patients are on highly effective contraception. They must have annual reviews with their specialists, and they must sign a risk acknowledgement form, and this copy will be kept by the patient or the carer and also one sent to their GP. So how can pharmacists get involved? Well, we can ensure that a patient card is provided to the patient every time valproate is dispensed. We need to remind patients of the importance of actually getting pregnant whilst they are on valproate and why there is a need for highly effective contraception. Ideally, valproate needs to be dispensed in its original packaging. Reason being is because if you look at any of the valproate products that there are, in their packaging there is on the front a label which says that it is teratogenic and the risks that there are. So if it is having to be redispensed in a different, or repackaged even in a different packaging, then we have to make sure that there is a PIL in there, and that also that there is a warning sticker on the outer box as well. So like I said, not in all situations can it be dispensed in its original packaging. So if it is repackaged, make sure that warning label is there. And if women are of a childbearing potential and they report that actually they're not taking highly effective contraception, then we need to get involved. We need to refer them to their GP, and if need be, we need to contact their GP directly if necessary. So this is something that new has come about. So, and again, the exam might want to ask you this question because it is something new that has come to light. But valproic acid, sodium valproate, women and girls of childbearing age, they have to be under the pregnancy prevention program. And you might be thinking, why have I heard of the pregnancy prevention program before? That's because the pregnancy prevention program has also cropped up in, again, women and girls of childbearing age who are taking isotretinoin. As well as those MHRA updates and changes in NICE guidelines, there are also a few dosage changes and updates too, so do check them out as well. Some of them include budesonide for its use in Crohn's disease, chloroquine in rheumatoid arthritis, different dosages of lisdexamfetamine in children, as well as different preparations have been updated. For example, there are now ciprofloxacin ear drops which are available but only in Scotland at the moment for the use of acute otitis externa. So for more updates and changes, do make sure that you check out the link in the description box below. So I hope you found this video useful on the changes that there are now in the BNF 75, as well as the MHRA alerts that are now available. And I hope you found this video useful and you liked it. And if you did, why not give it a thumbs up? Share, subscribe, do visit my Facebook, Twitter and Instagram pages as well at SureenaSpeaks. And until next time, good luck with your revision and happy revising.